Good afternoon, good morning, good evening, whichever suits you and wherever you are. My name is Ann Brazo. I'm the CEO and founder of MPN Advocacy and Education International. This week, we've been focusing on MF, polycythemia vera, and today, essential thrombocythemia. You'd think I'd know that by now. And we are with Dr. Gabby Hobbs in Boston, and we are so grateful for you being here today. I so appreciate it as always. And we have so many questions, but I'm going to let you just explain what ET is and for the new patients who are joining us today, and anything else you'd like to add, and then we'll get into our questions.
All right, great. Well, thank you, Anne. It's so nice to see you, and thank you so much for inviting me to be here. Thank you, everybody, for joining and taking some time out of your day to learn a little bit about essential thrombocythemia, whether or not you're a patient or a friend or caregiver or loved one of somebody with this diagnosis. Hopefully, you'll find today's conversation useful. So, to get started, essential thrombocythemia, or ET for short, is one of the myeloproliferative neoplasms, or MPNs. MPNs are the broader category of diseases of the bone marrow, and ET is one of them. So ET is usually associated with high platelets, but not everything that has high platelets is essential thrombocythemia. In fact, most patients that have elevated platelets probably don't have ET. And so making sure that the diagnosis is correct is definitely important. So in addition to having high platelets, the bone marrow of patients with ET looks a specific way. And in addition to that, the vast majority of patients that have this diagnosis will have a mutation in one of their blood-forming stem cells that makes the diagnosis easier. So before we had the ability to make these, to do these genetic tests, making sure that there weren't any other causes that caused high platelets was much more important. Now that we can more easily check for genetic mutations, we kind of do that first. So the most common mutations in ET are similar to the ones that we see in the other MPNs, and they really mimic the frequency of mutations in myelofibrosis. So JAK2 is the most common, occurring in about 50 to 60% of patients, followed by calreticulin that happens in about 25 to 30% of patients. And lastly, a mutation called MPL that occurs in about 5% of patients. And then there's a small group of patients that really don't have an identifiable mutation. And so for those patients, doing a bone marrow biopsy, I think, is particularly important. So once a diagnosis is made, the next decision that needs to be made is, does a patient require treatment? So most patients require aspirin, except for those that are very low risk. So those are patients that are young, that don't have cardiovascular comorbidities, have not had blood clots, and have a calreticulin mutation. Those patients really don't require even aspirin. The next decision, whether or not you're on aspirin or not, is, do you need medications to lower your platelet count? So platelet count number is not a reason for starting a medication to lower blood counts, for the most part. Patients that are considered high risk, those that are over the age of 60 and have a JAK2 mutation or have had blood clots before, those patients need to be on what's called cytoreduction, or medications to lower their blood counts. Other reasons for starting medications to lower blood counts are if a patient has a lot of symptoms from their disease, or if a patient has bleeding as a result of having very high platelets. And we can talk more about that. I'm sure that'll come up with the questions. So once a patient decides, whether or not they need to be on medication with the help of their clinical team, then a patient can have a discussion about what medication, and I'm sure that'll come up with the questions. The medications that we have available for the most part for ET are hydroxyurea and interferon, and then some patients occasionally will still get an agrolide, and probably a smaller percentage of patients will end up getting medications in what's called an off-label fashion, meaning it's not approved for that indication, but maybe they have a reason for being on that. And the most common one for ET would probably be Jakafi or ruxolitinib. And so, once you're on medication, you see your clinical team, and we can talk a little bit more about that with the questions. But things that patients usually, ask me about or are concerned about is, what can I do to stay healthy? And usually I say, you can think about this condition as another cardiovascular risk factor. And what are cardiovascular risk factors? Having high cholesterol, having diabetes, those kinds of things. And so in the same way that you manage those by seeing your primary care doctor or cardiologist or endocrinologist, we have to manage ET as well to prevent patients from having blood clots, which is really the most common complication of this disease. And so staying healthy, being active, eating well is also really important to preventing blood clots and to managing those other cardiovascular risk factors. So in addition to, deciding what type of therapy you need to be on, taking care of yourself in general and seeing your other doctors, there's also lots of research. And so patients ask me about that. And there are different medications that are being studied for ET. And many of these are medications that maybe started out as medications that were being investigated for myelofibrosis, but are now kind of trickling down to PV and also ET. So medications that are being investigated are, for example, the LSD1 inhibitor, bomedemstat. That's had some positive results. Pelabresib, which is a BET inhibitor, as well as ropig interferon or besremi. So there's definitely research in this area and lots of hope for patients with ET. And with that, I think that I'll open up the discussion to questions.
I don't think we have any. No, I'm kidding. That
Sounds
was
good.
such a
I'll
great
see you later.
story. Yeah, that was wonderful. Thank you. Oh my
Okay,
gosh.
sure.
Okay. Well, one question that popped into my head is, are you seeing more young women? We're hearing from more young women with ET.
It's funny
And
you mentioned that. I've had a 19-year-old and an 18-year-old in my clinic in the last 2 weeks. So
yeah,
that's
yeah,
anecdotal, but I think, Anne, with recognition of these diseases and with the ease with which we can do genetic testing, I think that patients are getting diagnosed earlier.
yeah,
Uh, and so epidemiologically, we don't think that the incidence hasn't changed. It's just more that we can detect it. Whereas
right,
before, primary care doctor would be like, "Oh, your platelets are high. Let's come back and repeat them." Now they're just more even. I've had primary care doctors that do the JAK2 testing, whereas before it was just really just a specialist that knew how to do that.
right,
So I think that that's a change in practice.
right. And that's why we hear from people, years later that say, I think I had this a
Yes,
long
exactly.
time
That's
ago,
exactly
but
right.
but it wasn't diagnosed. So we're just going to jump into these questions. I have so many questions.
Okay.
All right. How and when, and I think you kind of hit on this a little bit, but how and when do you factor in the allele burden when determining treatment in your ET patients that are JAK2 positive?
One day I'll have a better answer to that question, but right now we really don't.
Yeah.
And so when we look at an allele fraction, patients that have a higher allele fraction, we think are more likely to have more of that PV,
Yes.
fall more on the PV spectrum. But as much as we'd want to use the JAK2 level or variant allele fraction to guide our treatment decisions and how we monitor patients on treatment, the reality is that this is really not ready for prime time, even though patients ask for it all the time. And the reason I say that is not because we can't test it.
Mm,
It's just that we don't know what to do with those results. They don't inform clinical decisions. And so I've had patients that want to get tested and then they end up with a big bill from their insurance. Or I've had patients that get tested and maybe they were on interferon but only for a year. And so after 1 year the changes in the mutation is really very insignificant.
mm,
And so patients can get discouraged, but it doesn't mean that the medicine isn't working. It just means that the medicines are slow. But I feel that in the future, the testing will be better, more reliable, and cheaper. So we won't have the issue with insurance.
mhm.
And also, our medications will lower that level more consistently, like we see in other diseases, like chronic myeloid leukemia, for example, where that's totally part of standard of care. You have to
Yeah.
get to certain levels at certain time. And so this is rapidly evolving, and I really do hope that in the next couple of years, I have a better answer of how to use this
Well,
in a scientific way.
the interesting thing is we had Dr. Bose on yesterday for PV, and he said the exact same thing. He said,
At
yes,
least
the
we're
allele burden
consistent.
is it's significant, but we don't know what to do with it yet,
That's right. That's
So it's
right. We're working
interesting.
on it for sure.
Yeah, yes, of course. So you mentioned staying healthy. This question is, we all hear about how important exercise and a healthy diet and sleep and all those contributing factors that keep us healthy are in coping and living with ET, in addition to making patients feel better with perhaps fewer additional health problems. Does all of this really help to prevent clotting, heart attacks, stroke, statistically speaking?
100%.
I was just going to say,
100%. And
yes.
of all the things that we have literature for, diet and exercise, it's so interesting how like all paths lead to the same recommendation. Um, this is really absolutely evidence-based. And
Yes.
it's not just MPN evidence-based. I mean, we know from tons of large epidemiologic studies and just large studies in cardiology where there's many more patients, the diet and exercise make a difference. They make a difference in terms of keeping your cardiovascular system healthy, preventing the development of high blood pressure or treating high blood pressure, improving your ability to manage your blood glucose and keeping your glucose levels at a healthy level. And all of those things equal prevention of blood clots. When we think of blood clots, we don't always think about heart attacks and strokes, but really that is what we mean by that.
Mm-hmm.
And so having a healthy diet, and again, don't have to overthink it. It's eating the things that we already know we need to be eating. There's not an MPN specific diet. There's a life specific diet, and it's not a diet. It's just a way of eating.
Right.
More fruits and vegetables. We hear it all the time. And really, that's what it is. It's not a fad. It's not something that you do for a month and then you go back to doing something else. Fruits and vegetables, whole grains, less processed stuff, less red meat or avoid red meat altogether, and just less animal protein in general. And all of those things are important for all the cardiovascular conditions, including your MPN. And moreover, I'll say something that's maybe a little bit out there, but if you manage your cardiovascular risk factors by eating the healthy stuff and by being active, you're also going to lower inflammation in your body by having less of the bad fat and more of the good stuff. And inflammation is really a big contributor to symptoms in patients with MPN. And so I think that exercise and a healthy diet can really help people specifically with MPNs to feel better, feel more in control of their disease, and just be more in control of their destiny. So absolutely.
Yes, thank you for that. Absolutely. And you know, I love what you said about it's not a diet per se. It's just what we should be eating, period. And we all know when we've eaten the wrong thing and how they've affected us.
And I would say that of all the things that we work on in general, like
Yeah.
learning how to consistently eat the right things is not easy. So I have many patients that kind of beat themselves up, feel guilty about the things that they should be doing. And they're like, no, 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 Dr. Hobbs, I just know what I need to do. I'm just going to do it. It's really hard, actually.
Yeah.
It's kind of like
Yeah.
harder than quitting smoking. And so
Yeah.
don't be afraid to ask for help and get help from a nutritionist or from a peer group or from anything that keeps you accountable, because really what you're trying to learn is how to change these habits in a permanent way.
Right.
And for some people, they're able to do it kind of all at once overnight, but really for the most of us, it's changing a lot of little habits one at a time. And so
Yes.
don't feel bad if you just aren't able to just do it. You need to get some help from other people.
Yeah.
It doesn't have to be like
We
you're
are going to bring a nutritionist on, not today, but in the
it's
future,
super
near
helpful.
future,
Yeah.
and possibly at the women's event, we might have
Oh, that
somebody
would be
as
great.
well. But it's important, and also, you know, we have a staff person, Natalie, who does yoga and meditation, and those have been pretty successful. And of course, there was a study that absolutely indicated how much better our patients felt. So, and I agree with you also, having been in breast cancer and prostate cancer before this, the work that I was doing there, definitely every disease group talks about
It's the
healthy
same
eating,
message.
healthy exercise. Absolutely. Yes, the very same message. Okay, my platelets go up every time I have a COVID vaccine. Where can I report the side effect? I tried to report to the CDC to no avail. Is anyone researching this? My doctor doesn't think it's connected, and I wrote to Dr. Messa, and he doesn't think there's a connection either.
Mm.
My platelets were normal until I started getting COVID shots in 2021. That's interesting. Wasn't Dr. Pettit doing some work in compiling some data
Yeah, maybe so.
from MPN patients?
I think there is actually research. I don't think that you're alone. And you're not the first person that's noted an observation of a variety of different things with COVID vaccines. Um, the first thing I would say is anytime a patient with ET gets sick, their blood counts are going to be different than they are normally. And that is a normal response, so when any of us are sick, that's a signal to our body to change, our blood counts. And so what we think about most often is the white blood cell count going up with an infection, but actually high platelets also happen as a response to inflammation. And the COVID vaccines, not just the COVID vaccines really, but any vaccine, are big inflammatory signals to your body. And so, having an increase in platelets after a vaccine is not it's not surprising. Now, whether the COVID vaccine caused platelet changes to go up in a permanent way, I think that that's harder to prove, and that would require kind of knowing more about your specific case, and then obviously we need to just generate a lot of data by following a lot of patients and seeing what's happened with them. But a transient worsening of platelets with something like a vaccine is not entirely surprising.
Yeah, because I can vouch for, not feeling great after I've had
Definitely not. I know,
after
I
I've had
dread
the
every time I
COVID
have to get
vaccine.
one.
And I'm going to get another booster. This will be my 6th or 7th, I can't remember, but after, because it's been 4 or 5 months for me. And I thought, well, I'll do it today, tonight. So you can sleep through it and,
Yeah.
wake up tomorrow, hopefully feeling okay. But okay, so you mentioned about the bone marrow biopsy, and this is a newly diagnosed patient who says they were diagnosed through their blood tests alone, but would you recommend a bone marrow biopsy just for a baseline?
This is really a personal decision. Physicians and patients alike have lots of different interpretations of guidelines and opinions personally. And so the textbook answer, if you were answering a test, is yes, a newly diagnosed patient needs a bone marrow biopsy. And the reason for that is it is really difficult by looking at blood counts, especially in patients that have JAK2 mutations, to truly distinguish between essential thrombocythemia and polycythemia vera. And it's very common for a patient to be diagnosed with ET by blood counts, like you said, but really when you look at the bone marrow biopsy, it looks much more like PV.
Mm.
It is also really difficult to distinguish essential thrombocythemia from prefibrotic myelofibrosis and myelofibrosis just by looking at blood counts. And so those are good reasons for doing that initial bone marrow biopsy. If you're a younger patient, having a bone marrow that is your baseline gives the pathologist something to look back at later. Now, all of those things in real life actually play out very differently. And I sit with patients every week in clinic. And the truth is that for some patients, it really just doesn't make any sense. It's not going to change their management, meaning, you're going to get or not get the same medications no matter what that bone marrow biopsy shows. For some older patients with a lot of anxiety, with lots of issues, really that initial bone marrow biopsy just doesn't give enough benefit to make it worthwhile. And so it's not incorrect to not want to have that bone marrow biopsy at diagnosis, but there's some patients that are like, listen, I just need to know if I really have ET or if I have PV. I really need to know if there's some fibrosis in there or not, some scarring. And so for some patients, the bone marrow biopsy is very helpful. It gives them some peace of mind. And so for those patients, I really encourage them to do it. And so it really is an individualized decision, despite what the guidelines may say. It's not that black and white.
Okay. Everybody wants to know about progression. And would you say you've been able to identify just through the patients you see, perhaps, when you see signs of progression, and what are those?
Yeah, sure. Progression is definitely something that patients worry about. Remember that compared to PV, patients with ET usually progress less. That varies a little bit patient to patient and depending on their mutations, but in general, progression doesn't happen that frequently, like less than 15% of the time. And that's 15, not 50, 15% of the time, over the course of a decade or two. Okay. The longer you live with this disease, obviously, the higher the likelihood of something happening just because, you're around longer. Signs of progression. The first one I would say is looking at blood counts. So when people start to develop some fibrosis, you can see, cells that are in the blood that don't belong there. The one that I find to be most helpful as a kind of like a marker of fibrosis, I call it my poor man's bone marrow, is nucleated red blood cells. These are cells all of our red blood cells in the blood don't have a nucleus. They don't have the central part where the DNA is. They're just kind of bags of hemoglobin. And so if you see red blood cells that have a nucleus, that means that the bone marrow is shooting out cells from the bone marrow before it's their time. And so that's one indicator. Another classic one is, if patients were on, 2 pills of hydroxyurea or 3 pills of hydroxyurea or whatever number of pills for their disease, and all of a sudden with that same dose, your blood counts are really low. That's a sign that maybe the bone marrow is like, quote unquote, getting a little tired, and so the blood levels are kind of coming down. So changes in the blood counts in that direct, that are going down is an indicator maybe of developing fibrosis. When patients develop symptoms, it's not necessarily a sign of progression, but if the development of symptoms occurs at the same time that the patient is also kind of like developing an enlarged or bothersome spleen, those two things together start to feel a little bit more like fibrosis. But it's usually not something that happens overnight. It's something that hopefully you'll be able to kind of monitor with your clinical team so that you have a sense of what's happening. It's kind of this like slow slide into fibrosis. Not always, but.
Mm-hmm. So to that, this question, the next question is about progression, but it's also about the drugs that are out there, the new drugs that have been approved currently. I think there are 4 now, but also any drugs that you are seeing in clinical trials that are showing promise with curtailing or stopping progression.
So when we're talking about drugs that are approved, I think the drugs that you're mentioning are the JAK inhibitors. Those are really approved for myelofibrosis, not for essential thrombocythemia. And then ropig interferon or Besremi is an interferon that was approved for polycythemia vera and is being studied for ET, but not yet approved. So unfortunately in ET, we haven't seen recent drug approvals, but that doesn't mean that there isn't ongoing research in ET. And so for ET specifically, there's an ongoing study utilizing ropig interferon or Besremi that's, I think, finishing accrual. And there are 2 different studies with an LSD1 inhibitor called bomedemstat that was initially studied in myelofibrosis and is now being studied in ET and I think also in PV. And that's shown, improvements in platelet counts, and we're starting to learn about the decreases in the mutations with those agents. And similarly, pelabresib, which is a BET inhibitor that was initially studied for myelofibrosis, is now also being studied for essential thrombocythemia. So still kind of early days, so hard to tell you, does that reverse anything or prevent progression or anything like that? We don't know. I think the molecule that we have most data on is interferon. And, we've had different interferons that we've used for many decades for MPNs, including ET. A long time ago, we used to use the traditional not pegylated interferons, which means that, patients had to give themselves that medication like several times a week, and it was really difficult to tolerate. Thankfully, since then, there's what's called pegylated, meaning it's something that you add to the molecule that makes it last longer in your body. Pegylated interferons are much better tolerated, and collecting data from Pegasys and Pegintron, and then more recently ropig interferon, I think we do have some good data to suggest that utilizing these types of medications lowers the mutation level and can help delay progression potentially or help people live longer. These are not solid data that are enough to say because of this then everybody should be on an interferon, and so we're kind of waiting for more data to be collected to really be able to say that. But I feel, I think that over the last couple of years, my practice has definitely shifted towards prescribing more interferons if possible, especially because they're better tolerated now.
Right. What are the signs or key indicators of a patient that's actually in remission?
Great question. So again, there's like the pathologic and clinical trial definitions, and then there's just like the, you're a doctor in clinic with your patient. And so having blood counts that are well controlled, having a patient without symptoms of disease are clinical definitions of, quote unquote remission. It's just that we don't use that term because actual remission means, you do a bone marrow biopsy and it looks normal and you check the mutations and they're gone. So most patients don't fall under that strict definition of remission. But hematologic remission, meaning your blood counts are normal, is something that we definitely aim for, and is the main, the main thing we try to do with lowering your blood counts with medications. And equally important is managing symptoms. And so those are the two things that we really look for in clinic.
Right. And then we hear this quite often about night sweats. And the question is this related to my ET?
Right. So I think it's important to think about what a night sweat actually means. It's not that you got a little sweaty because you have a lot of blankets, or it's not that you're having hot flashes because you're going through menopause. It's the feeling that you have when you have a flu and you break a fever and all of a sudden you're in this cold sweat. That's a night sweat. So most patients actually don't have night sweats, and I don't mean to say that in a dismissive way at all. It's important to just know, are you actually having night sweats? Because I don't want you to worry about something that's not actually a night sweat. Anyway, that being said, obviously some patients don't sleep in a hot room, don't have a ton of blankets, aren't going through menopause, and then they have like weird sweating at night. I've had lots of patients who are like, it's just a strange thing that happens to my head, and like I wake up and I'm like, my head is sweaty. And so there's probably, there's some part of this that's not as scientific, and certainly some patients just know, and as a provider that's been treating this for a long time, there's something about that that's probably related to their condition. And the symptom by itself, it's not that it's dangerous to you. It's just something that may be bothersome that requires potentially considering treatment to avoid having to wake up at night a few times to change your clothes, because that's a big deal.
Yeah. What is known, if you know, about the ZRSR2 mutation? That's a new one for me.
No, it's a mutation. There's a group of mutations that are kind of similar, and we know more about them for myelofibrosis. We don't know enough about them for essential thrombocythemia. When we think about ET, we think about risk stratifying patients based on their risk of having a blood clot, and based on that, we determine whether or not they start treatment or not. But there is a new score called, or a newer score, I should say, for ET called MIPS-ET.
Mm-hmm.
And there they tried to look at a variety of different risk factors to try to get a better sense of, kind of survival. And there they included some high risk, they found some mutations that are associated with high risk, and they included SRSF2, SF3B1, U2AF1, and P53. The mutation that you mentioned is just not that common, and so then it's hard for it to kind of come out as a significant mutation. And so one of the downsides, of doing mutational testing for patients with ET today is that we find out these mutations, we think that it's probably worse to have them than to not have them, but it just doesn't change how we guide you in terms of your prognosis and your treatment.
Mm-hmm.
And so that's really a real struggle that I have, where I think it's important to collect these data so that we can one day make more informed decisions based on those mutations. But right now, we get that information and then we really don't know what to do with that.
Yeah. Yeah. Why are cytoreductive treatments needed, and why are they helpful for reducing incidence of thrombosis?
Great question. So
Yeah.
when we talk about cytoreduction, we're saying, reduce the amount of cells that you have in your body, specifically your blood cells, right? And the reason why cytoreduction is given is because studies have shown that lowering blood counts equals less blood clots. Similarly, giving aspirin for certain groups equals lowering blood clots. And so the reason why we give these medications is because we want to prevent blood clots from happening. And so, up until now, the recommendation for giving medications to lower blood counts has been specifically to prevent blood clots, and in ET also prevent bleeding. My hope is that as we, have more experience with medications like the newer interferons, also potentially with JAK inhibitors or with new molecules that are being developed, that an important goal of treatment becomes not just lowering blood counts, but also preventing progression. But we're not quite there yet. Hopefully we'll get there. So for now, although of course patients, and I completely understand why, are much more concerned with progression, a much more common occurrence in ET and PV is having blood clots. And so that's why the focus of treatment has been lowering blood counts to prevent progression, Um, because that's the most common occurrence, but also because that's all we could do. So
Right.
hopefully, as medicines move forward, we're able to do both things.
Yeah. How do you determine the difference? And you were saying it's kind of difficult to discern from a slide of, PV and ET, but how do you determine the difference?
So you don't do it by blood counts.
Okay.
You can guess by blood counts. Like if I meet a younger male patient that has pretty normal white count, pretty normal red counts, and they have ultra high platelets, yeah, I'm pretty sure that person has ET with a calreticulin mutation.
Mm.
Um, but you can't always tell. You can't always tell. I've had patients that look just like that, and then they actually end up having chronic myeloid leukemia, which has nothing to do with ET. And so, although we can guess by looking at counts, really, the mutations help guide us, and the morphology, or what the bone marrow biopsy looks like, helps to guide us as well. So really the bone marrow biopsy does look different in each of the conditions, whereas in ET it's more the platelets are abnormal or increased in number, and PV we have an increase in all sorts of blood counts, in all sorts of blood cells, calling that pan-myelosis, meaning all of the blood precursors are elevated. And then lastly, in myelofibrosis, you have scarring that's seen in the bone marrow, with also, things looking a little bit different. So the bone marrow, you know, despite what I said before, is really the gold standard, is the way that
Mhm.
we look at the blood counts and the mutations and the actual bone marrow, what it looks like, to come up, with the actual diagnosis, as opposed to just a little bit of guessing. But oftentimes, you're able to make an educated guess.
Yes, yes. What is the threshold for platelets before you recommend additional medication other than aspirin?
Very controversial question, believe it or not.
Yeah, I was
So
gonna
people feel
say,
very differently about that.
yes.
There's no threshold, really. I think that docs start to get nervous, and patients probably start to get nervous above 1 million or 1,000, depending on how you interpret the units of measurement. And definitely more nervous after 1.5 million. But I certainly have patients that are completely asymptomatic, like have no symptoms whatsoever, have no issues with bleeding, have no cardiovascular risk factors, etc. And so there's not a number where you say you have to be treated because of the number.
Yeah.
Most people do end up getting treated simply because the combination of the clinical team and the patient get anxious and just put them on therapy, or find a reason to put somebody on therapy.
Okay. And this is a good question, and one that comes up very often. Actually, usually the MPN specialist will recommend that our patients, and we do this as well, will say, if there's any way for you to see an MPN specialist in your area, we can recommend someone. And the question is my hematologist, my local hematologist, adequate enough for me for my treatment? Or do I really need to see a specialist? And the caveat to this is, what if they can't afford to go see an MPN specialist? That's why we always try to do, my whole goal when I started this business was to bring the mountain to the people,
I love that.
and to make sure that they were getting adequate information and accurate information from an MPN specialist. But what would you say to this person?
Yeah, what a good question. I think with events like this one, and with availability of lots of information online, many patients are really very informed. I'm really impressed sometimes by patients that come to me with, like, New England Journal articles and all sorts of things. So it is possible as a patient to get very well informed and complement the care that you're receiving. That being said, I think there are some limitations to how much you can find online. I spend a lot of time talking to patients about what they learned on their Facebook group or their whatever. Because
Mhm.
remember, sometimes when patients are online, like, it's not a representative group of patients. There's some patients the patients that are doing well and working and traveling and having kids and doing all these things probably don't have time to go online and say, hey, I'm doing great. And
Mhm.
so remember that, you have a group of patients that are telling you, whatever, I had this disastrous consequence to something, and it's probably like 1 in 1 million, but
Mhm.
because you read it on the group, it feels like it's more common. And so, um, although there's a lot of great information online, that doesn't substitute for an encounter with a clinical person. And so if you are able to get a second opinion, even if it's a one-time second opinion,
Mm.
I personally find, and of course I'm biased because I happen to be that person that gives those opinions, my experience is that patients leave those visits feeling empowered, reassured, educated, and with an idea of what they need to do moving forward. And for many patients, I tell them, even if you only see me once a year or even less frequently, once you're a patient, you're always a patient. So you can always reach out again and say, hey,
Mhm.
I started this medicine, it's been a year, whatever, and now I have this issue or that issue. Can you help? And so it's just nice to have a person that you can go to for that. I would say that not everybody needs that. I mean, if you're only on aspirin and you're feeling fine, you have no side effects, you're etc. That doesn't, you don't have to go out of your way to get that expert opinion. But so a little bit of it depends on your level of curiosity or anxiety or etc. And also how you feel with your local doc. If you
Right.
have a wonderful local doc that is able to explain to you what you have, give it a name, explain to you why or why you don't need to be on medication, etc., yeah, you may be fine. I find that I have some patients that have had high platelets for like a decade and they come to see me finally and they're like, I just know that I have had platelets, but nobody ever explained to me why. So if you're one of those patients where you're like, nobody told me why, yeah, you probably need a second opinion.
Mhm.
Um, I think one of the things that COVID has given us, in addition to the ability to have these types of webinars, is that a lot of doctors will do telehealth visits
Mhm.
also.
Mhm.
And most insurances will approve like a one-time visit, let's say, to a specialty referral. Um, and so there's enough experts throughout the country that maybe you can
Yes, because
do that one visit. So I think
that
there's value.
and just to let everyone know that your insurance sometimes will only cover it within the state that you live in. And so a tele medicine appointment. But so make sure you find that out first. But I love what you said about once a year. Some people see a specialist every 6 months or,
Right.
depending on their need. But what I have found with you and with others that I just can't express my deep admiration and respect for is that they are willing to see you however they can and talk
Right.
to you and to share and collaborate or discuss with your hematologist, your local hematologist, what's going on. And what I love about some of the patients is they take this information to their physicians. And
Right.
if you have a physician that is humble, that is open, that is willing to listen, that's a great thing. That's a
Mm.
great attribute because you'll just feel at ease, much more at ease. So moving on, what are the treatment options for ET patients currently?
Yeah, sure. So the first is aspirin, and that can actually help not just to prevent blood clots, but some patients really have a significant improvement in symptoms. And I think my ET patients are probably the ones that have benefited the most in terms of symptom improvement from ET. The most common symptom that gets better with aspirin is headaches and then numbness and tingling. I've had lots of patients with ocular migraines and stuff like that that really get so much better with aspirin. For pregnancy also, aspirin is critical. So that's
Yes.
aspirin. I can't underestimate aspirin. Um, the other medications include hydroxyurea, interferon, and rarely but occasionally used anagrelide.
Mhm.
Hydroxyurea has been around for a long, long time. It is a form of chemotherapy, but it's kind of like low dose chemotherapy. People can be on it for many, many, many years. It's usually thought of as a safe medication. It's cheap, it's well tolerated, it's easy to adjust. Um, and it's been around for a while, so we know all about it.
Mhm.
Interferons have had multiple iterations, like I was talking about before, the older generation that was harder, and then there's newer medications, Pegasys and Pegintron that are given, once a week. And then more recently, we've had the approval of ropeg interferon, which is given once every 2 weeks for patients with PV. And I would expect it to be hopefully approved for ET soon as well. And then there's anagrelide, which is a medicine that really only lowers platelets. So for some patients, that's particularly helpful, but it is a difficult to tolerate medication because it can cause a lot of palpitations. And so I really very, very rarely use that.
Mhm. So, as we mentioned earlier, there are a lot of younger people being diagnosed with ET, PV, and on occasion we hear from a young person with MF.
Mhm.
In this case, it's a parent. My son has ET and was diagnosed in 2020. He is currently on aspirin to manage his headaches and also has an enlarged spleen. Are these symptoms related to ET, or should we do additional tests?
Sounds like they're related to ET.
Mhm.
However, it's hard to know without knowing anything more. And I would just make sure, especially if your son was diagnosed at a young age and has lots of symptoms and a big spleen, that a bone marrow biopsy has been done to just make sure that your son doesn't have myelofibrosis. And especially if they're young, that's especially important to know. And they may be eligible for different therapies, like the JAK inhibitors, for example, that wouldn't be traditionally thought about for essential thrombocythemia.
Okay. And this gentleman, or woman, I have had ET since 2017. At the time, they were 30 years old. My platelets are between 857 to 900, and I'm on aspirin, 81 milligrams. And the only symptoms that I have are migraines. I hear that quite often. In
Mm.
fact, we did a migraine study, and it
Did
was,
you?
yeah, and it was 90% female, had
Yes.
females had headaches and migraines. If I take aspirin, then the migraines go away. Should I consider switching to interferon? And I know you're not this person's physician, but just,
Listen, I mean, I think, like I was saying before, aspirin really helps people with symptoms. And so if aspirin helps, then that sounds great.
Mhm.
For some patients, they need to take aspirin twice a day, 81 milligrams twice a day, and that helps with the headaches. Um, the other thing that's important to note, which is true of headaches, but also of many other things, as an MPN patient, you're not just an ET person. You also are a human being that has other things. And so headaches are common also. And so you know, making sure that there isn't anything else that can be done for headaches in general is important. Have you always had headaches? Are these new headaches? Are these headaches related to your menstrual cycle? There could be other much more common reasons for having headaches that should be managed, for that more common reason than for ET. Um, but if all those things are really not related at all, and it just is the platelets and the ET, and aspirin is not making a difference, then that's not a bad reason for considering a medication to lower your platelets as an experiment to say, if we give you a medication that lowers your blood counts, do your symptoms get better? But it sounds like, for you specifically, you're saying that with aspirin, they go away. And so I would say probably stick to aspirin if that works.
Yeah. Um, let's see, I just lost it. Oh, I was diagnosed a year ago and I'm 25 years old. I was put on hydroxyurea because my platelets were 1600. Is this the best option for me? I am triple negative and cannot find much information on this.
Great question. Difficult situation. Well, first of all, I would say if you're that young and you don't have any mutations, for you in particular, I would really highly recommend a bone marrow biopsy and seeing a
Mm-hmm.
specialist.
Mm-hmm.
So once the diagnosis of ET is confirmed, and I'm assuming that it is what it is because 1600 is really high, and so there's probably nothing else that would do that. But it is important to make sure you've had a thorough workup and have been looked for, chronic myeloid leukemia, for example, because like I said previously, CML can oftentimes look like ET, and so making sure that that's been ruled out is important. So once we feel comfortable with the diagnosis, if we need to give you a medicine to lower your blood counts because you're having symptoms from the high platelets, or you're having increased bleeding from the high platelets, which for a young woman oftentimes comes in the form of very heavy menses, then I would say my preference for you would be to start you on not on hydroxyurea, but on an interferon, as a way of lowering your blood counts instead of hydroxyurea.
Mm-hmm. This person, and you've discussed pretty much bone marrow biopsies, but they have one every 3 years. And are they checking to see if I'm progressing to AML or if I'm just progressing? Is this accurate testing or is it necessary?
What a good question. And I'm sorry to give the answer this way, but I do not believe in scheduling bone marrow biopsies. Like that's not recommended anywhere. It's not in any
Yeah,
guideline. You get a bone marrow biopsy if it's going to change your management. If your doctor is worried that you're progressing, checking bone marrow biopsies every 3 years to tell you you have ET is not something that I recommend. I would not do it.
yeah, yeah. This person says I tend to have anemia often, and my doctor keeps telling me to eat more red meat, but I prefer fish and seafood. What should I do?
No, I would agree with you. More red meat is never the answer. So one thing that's important to recognize, like I was saying before, an MPN patient can also have other issues. If you haven't had a colonoscopy, you need a colonoscopy. It's important to make sure that you're not iron deficient. If you're iron deficient and we don't have an explanation as to why you're iron deficient, that's important. And there's better ways of replacing iron than by having more red meat because that's bad for your health. So
Mhm,
taking iron, for example, or even having IV iron. But it's important to realize, to work up and have an explanation as to why you're losing iron or missing iron. No matter how much of a vegan you may be, it's actually really difficult to become iron deficient just from diet.
mhm,
And so making sure that, you've ruled out, blood in the stool, blood in the urine, etc. Or maybe you're not iron deficient at all. I mean, maybe it's something else. And so it's important to understand why
right.
the anemia is occurring. So anemia is just a general term that says you have low red blood counts. It can be because you're missing iron. It could be because you're missing B12, maybe because your thyroid levels are abnormal. Maybe you're drinking too much alcohol, or maybe it's your MPN, and maybe it's because you're on too much medication like hydroxyurea, or maybe it's because there's some scarring in the bone marrow, and this is turning more into myelofibrosis, and so the hydroxyurea or whatever medication you're on is causing some anemia. And so anemia is a complex thing that needs to be worked up more thoroughly, and just having more red meat is just not the answer.
Okay. Um, do you have any thoughts about the effectiveness of Rutin? Is there any
Of
reason
what, gluten? Is that what you said?
Rutin? It's a supplement of some sort. I don't know what this is, so I thought you might.
I don't have opinions on supplements, to be honest, other than
Yeah.
to say you have to be careful. They're expensive. They're not regulated. And my personal preference is just to have a well-balanced diet where you have all the vitamins and minerals that your body needs. I think, if a natural substance was able to cure MPNs, it'd probably also be so strong that it would have lots of side effects. And so, um, I wouldn't go out and buy lots of supplements that are expensive. I think even a multivitamin is not really necessary if you're having, fruits and vegetables in your diet.
I have had ET for 20 years with no symptoms. I have the CALR type 1 mutation. Is this fairly common?
There's definitely patients like you. And so,
Yeah.
and you're the type of patient that's not on Facebook saying, I'm doing great. So yeah, I definitely have patients like you, and that's great. I'm glad you're here.
This person, quite the antithesis of that question is, I am consistently sick, or I'm constantly sick with upper respiratory infections. Is that related to my ET?
Probably not,
Yeah.
to be honest. So, many other things contribute, age, other medical problems, and medications. So we've looked at response to vaccination in our patients with ET, including COVID and the flu. And
Mm-hmm.
ET patients really looked very similar to age-matched controls, or like normal folks that are of the same age. And so although ET may impact your immune system, I don't think that the contribution is enough to be the reason. I mean, maybe you're a parent of young kids. I can tell you I'm sick all the time, and that's because my little kids are petri dishes, And so, like I said, it's also okay to have regular ailments that affect all of us.
Is it true that having low iron or ferritin can also cause high platelets?
Yes, absolutely. So remember at the beginning of the talk, I mentioned that having high platelets, from other reasons is much more common than having high platelets and it being ET. The
Mm-hmm.
first thing that any decent doctor will think about when they see high platelets is, does this person have iron deficiency anemia? When a person is missing iron, and by definition, therefore, their ferritin is low, the ferritin is a indicator of your iron levels in your body. the first thing you need to think about is, are their platelets high because they're iron deficient? And that has nothing to do with an MPN, nothing to do with ET. Many, young women that have very heavy periods have high platelets, and then you give them iron and the platelets get normal.
I was one of those people.
You
I was. Is there any evidence that HU can reduce bone density?
mean like causing osteopenia or osteoporosis? Not that
Yeah, I think so. Yes.
yeah, not that I know of.
Yeah. Do you think Pegasys can reduce scarring in the bone marrow or interferon?
Yeah, that's what we're kind of waiting to have more definitive evidence from, but a lot of data, a lot of it from the Cornell group that gives a lot of interferon, and kind of more recent studies show that interferons in general can lower the level of the mutations, and maybe patients that have been treated with interferons for a long time have less chances of progression. And so there's not a reason not to be on an interferon. That's why it's usually my preferred agent in ET patients.
Mhm. We know there are side effects from all medications. I don't think there is one out there that we don't have some side effect from.
Right.
But for hydroxyurea, again, we all know that patients can be on it for many years and do well. But are some of the side effects of drug fever? Do you know? Yeah.
That's a harder one to answer. Some people, if you really are having fevers to a drug, that's probably a reason to stop that medication and then test
Yeah,
it out. That's really the only way you'll know if you're actually having fevers to that medication.
right. And so there's a couple long questions here. I'll try to edit these, but I've had ET since 2017. Oh, I already asked you that, sorry. My husband was diagnosed with pre-fibrotic MF. His oncologist assumed he had ET until he did a bone marrow biopsy. He's JAK2 positive and has no symptoms other than elevated platelets. I've heard some doctors on these programs say, call this ET with a little scarring. Does it matter what you call it with regards to prognosis?
The prognosis is what it is,
Yeah,
regardless of what you call it, for sure. And so we know that if the diagnosis is actually prefibrotic myelofibrosis, the prognosis is a little bit worse than it is with ET alone, and better than it is with myelofibrosis. If your husband just has the JAK2 mutation, the blood counts are otherwise pretty good, meaning their white count is normal and their red blood cell counts are okay, then he probably does fall more into the ET spectrum than the myelofibrosis spectrum. Um, and so I wouldn't be too worried about it. I mean, I think, some doctors just maybe feel uncomfortable saying prefibrotic myelofibrosis. So, definitely I have heard that ET with a little bit of scarring, but if they meet criteria for it, then the actual name is prefibrotic myelofibrosis.
so are you seeing less of um less fewer incidents of major problems with your patients with ET because of the new drug therapies and because of a better understanding of essential thrombocythemia these days, and the research? Do you see less incidents of perhaps patients showing up in the ED with a thrombotic episode, or is it kind of the same? Or
Well, and not really. And the reason, I mean, yes and no. So I mean, like, not to say no, nothing's better, but unfortunately, sometimes patients just their first presentation before they knew that they had
right.
anything is just with a blood clot, and that we haven't found a way to figure out how to, prevent that from happening. And so that's unchanged. Now, patients that have ET, if they're managed, if they're on aspirin appropriately or on a blood lowering medication, cytoreductive agent appropriately, yeah, sure. The goal of that is to lower complications. And so certainly, we see less complications in those patients, but preventing those initial presentations is still really hard to do.
Yeah. So in closing, we have a few minutes here, but I think there were a couple questions that were so long, I don't think it would be appropriate to ask here
Okay,
at this time, but we can email those and
sure.
try to find answers for these patients. But in closing, I always ask our MPN specialists to impart some wisdom or some hope for the future. And would you like to share, your thoughts on what's coming down the pipeline and what you
Yeah,
can
sure.
say to our ET patients here today.
Um, getting informed is really important. Don't let that paralyze your life. The goal is to have ET in the background of your life, not in the forefront of your life. And remember, there's lots of different medications that are being studied for all of the MPNs that are making their way to ET as well. So I know that in the future, we are going to have a very different conversation if we do this again, where there's going to be many different medications that we have available for ET that won't just lower the blood counts, but will also prevent progression, because that's really the goal of therapy, and I really do believe that that's where the field is moving. So don't lose hope, and also remember to take care of yourself, not just your platelets, but all of yourself, because all of the rest of your medical issues also contribute to your MPN. And so don't forget to go to your primary care doctor and get your mammograms and colonoscopies and all those things. Those are really important also.
Thank you. You're absolutely right. I love this and I adore you. And I'm so happy that you were with us today.
Oh,
And I'm
thank you
sure
for
our
inviting me.
patients and caregivers were too. I hope to see you maybe at ASCO or soon somewhere.
Sounds
And we'll
great.
be in touch. But thanks again, Gabby.
Thanks
I
for inviting
really
me. Thanks everybody
appreciate
for the
it.
great questions.
You're just wonderful. Thank you.
Thank you. Bye.
Bye.